Thank you very much. If I can just abuse my position as chair to ask you quickly, when you were in charge of the National Health Service in this country, were you ever aware of professionals coming from southern countries to advise or lead policy development in the UK in those 6 years?
No.
Right. Okay.
I think the only one might have been Julio Frenk when he was now Dean of the Public School in Public School of Public Health in Harvard, but from Mexico.
So that gives us a baseline.
It does, doesn't it? Yeah.
Okay. Great. Should we open this for a general discussion now? I think that was extremely clear. Thank you very much. It's
Thanks.
a very challenging and interesting presentation, and very much appreciate the emphasis on mutual learning and rights and if you like, global communities. So I don't think there's a need for clarification questions at this point. So let's move to a general discussion, and I'll take comments from the audience. Please introduce yourselves when you make your comment.
Mrs. Selvaratnam, Women for Justice and Peace. I can't wait to get back home and tell my friends and family about what I heard here and about your work. Thank you. Right. I want to tell you something which you haven't mentioned. Right. What about the people who are oppressed by their own governments? Which means, example, Sri Lanka, independence meant external colonialism transforming into internal colonialism. Political and economic oppression of 60 years has led to the decay or almost total decay of socio-economic fabric, leading to the degradation of health. Their average health and weight has gone down. Can you believe that? Yeah. And in the last, there have been decades of embargo of food, medicine into the Northeast. And if I look at the last 5 years of the present president, aid agents are prevented from going into the Northeast. And drugs are flooded by the army, the occupation army in the society. And I heard that some Sinhalese, conscientious Sinhalese have told the LLRC, the commission that is going on in Colombo, about this drug problem, the free availability of drugs, cigarettes and all that in that oppressed area. And last year, one doctor who went there from here, I went to this Maudsley Hospital lecture last year, he told the audience that when he went to the university lecturers told them that they have a huge problem, the students, the drug problem, and they said the suppliers are the army. I was in Sri Lanka, the northern region, soon after the peace process was declared in 2003. My cousins, first cousins, very close friends told me that the army is distributing pornography and getting school children and make them smoke cigarettes. So this is utter oppression or genocide in some form. You know, the research reports in the last few days, the last few years, they are not only preventing food from going into that area, they are preventing aid agents from counseling the traumatized people, and preventing counseling and preventing capacity building, preventing formation of cooperative societies in the Northeast. So this is utter oppression. What can they do?
Well, let me try and come back. Should we take two or three at the same time and then see if there's a theme emerging or whatever? Okay.
Thank you for a very interesting talk. I was very pleased that
sorry, can you introduce yourself?
I'm Mike Joffe from Imperial College,
right.
Epidemiologist, also economist. I was very pleased you stressed the need for a new paradigm, because as a person who inhabits both the world of health impact assessment but also as an economist, I see the ghettoization of health.
Yeah.
And there is a need for a paradigm, because if we compare this audience with the usual ODI meetings, I come to a lot of ODI meetings.
Yeah.
It's probably a very different audience. It's smaller. Most people in ODI wouldn't see health as relevant to what they do. But when they're talking about a whole range of issues to do with livelihoods, crops, nutrition, development. Actually, health is one of the main outcomes, but it's excluded systematically. And so I was very pleased that you talked about the new paradigm, but at the same time, I'd be a little bit critical that most of what you were talking about was health professionals. And there is no such thing as a health sector. There is a healthcare sector which mops up the damage that comes from biological and social determinants, and that's been well recognized for a very long time. So I would like to see more give and take on both sides. There's this siloization, what terrible word. Everybody's in their silos, and health is still in a silo. People see health as either healthcare, or if they go beyond that, as individual choices. I was doing, sorry to go on at length, but I did about 10 years of advocacy in the European Union, and to get people like MEPs to see health in terms of how health is socially created and how disease is socially created was very difficult because they were stuck. So I was very pleased to see that you talked about new paradigm.
Yeah, thank you very much indeed. Can we go to Enrique actually first? I think you were, and then
Enrique Mendizabal from ODI. I was noting at your sort of comments about the what I think is an intermediary between, say, health experts and health experts by international development professionals. But the same thing is true for economics, for education, for agriculture development, and is part of this is this industry of international development. I'm Latin American, and I started looking at it, sort of listening and reading about international development when I came here, because from the point of view of Latin American, it was just policy. So policy, health policy, microfinance policy, macro policy, and the so okay, my work is on think tanks, and I work a lot with think tanks around the world, and we get the same. We get people in the macroeconomic section of the think tank or the social development sector of the think tank want to talk to the experts in other parts of the world, not necessarily those who are sort of covering the globe, but those who are running excellent practices in their country. So the question is really, I guess, for discussion is whether the international development sector needs to either allow more specialized actors who are focusing on health policy in the UK, maybe economic policy in the UK, education policy in the UK, to participate directly without us getting in the way. With the DFID, for instance, we're just doing a study on DFID's advisory capacity, where the DFID has to have maybe more, health economists or clinicians or so the experts on the field, the discipline, rather than development studies or social development programs or graduates who've done a bit of everything. I went through that here as well. To be able to have that more direct link, because sharing of knowledge is easier between people of the same profession. You share language, you share tools, and it's much easier. Or whether ODI, and this is a question for Andy, I guess, whether ODI needs to bring in those people who are not really from the international development world, who not necessarily holistic or cross-cutting in their approach, but do have that very clear technical expertise and developed over a long career, and will probably have a much more interesting discussion with their peers in other parts of the world than if it's too general.
I think the interesting the health obviously brings a very material and very direct perspective to globalization, because of these, globalization can sound rather academic, but in this case you're talking about extremely easy to demonstrate practical ways in which the world of a health professional changes. Well, if you can deal with those, and then we'll take
can I pick up those three? And there's some commonality here, isn't there? I put that one back up actually because I absolutely take the point, and I do in the book actually try and spell out a bit what we have done in the UK under a sort of channel of health, direct health, wealth issues and societal issues. And whilst we didn't quite plan it like that, it is interesting to look at poverty reduction plans in lots of countries around the world who very explicitly do make these linkages in ways we don't. It'd be really interesting to see America do one of these. you know, for the United States. I mean, we sort of did it in the middle of that area is 1948 and the creation of the welfare state, where actually we did do reforms in health that reciprocated with reforms in education, which reciprocated with reforms in employment, and was our poverty reduction plan, wasn't it? In that sort of way. But it's I think some of the thinking that actually happens in countries around Africa could well be translated to richer countries and would help us to shift our health systems from being just clinical health systems into a much wider understanding. I think this is also relevant, though, you know, and can I say in my book I say a little bit more about this. Today's talk was slightly more focused on the clinical stuff. I should have said at the beginning, my publisher will never forgive me. I'm very happy to sell you a copy of this at the end for £10, special price, signed, or if you'd rather, or if you think it's more valuable for resale unsigned, I'll sell it unsigned. The lady from Sri Lanka and Women for Justice and Peace, well, thank you for your thank you. I think in a sense the same point is you can't do anything about health unless you do something about the other things. And I actually used a slide here which I didn't really dwell on, but when you look at the issues in poorer countries, that first bullet point wraps up an awful lot of things. You know, the problems of health are complicated by poverty, by social issues, and by internal and external power relationships. And you were just describing your own assessment of some very damaging internal power relationships, which were having an impact not just on societal health, but actually on physical health as well. And the examples I tend to use in the book are a bit more about gender power relationships and some of the issues around maternal mortality, which are to do with not just men's behaviour, but actually women's behaviour because of how society is organised in those countries. So power is something we underestimate in health quite often in terms of our analysis of it, but it's just as and whilst you see it clearer in countries which have smaller infrastructure, it's just as true in this country that power relationships impact on people's health in a very significant way. So yeah, I can't make any comments about Sri Lanka, but I think the audience heard what you had to say. Can I move on to Enrique? Well, we obviously agree, Enrique, in that the dialogue needs, in many areas, to be between the professionals in that area. And recognising that professionals in that area may mean community health workers as well as docs and nurses, but the people who are actually dealing with the business. You need the framework of international development, it seems to me. But wherever that first trip I did for Blair, I was on a sort of official capacity, and you talk to health ministers and say, well, you know, what could Britain do for you to help you with your... and the two things I tend to get, the first one was, of course, one had to have the discussion about migration. So the first one was stop taking our doctors and nurses. You know, that's the first thing that people said. But the second thing they said is actually, could you lend us the person who does that for you? So we're trying to set up a financial system. Could you lend us the guy who does it in the NHS? You know, we're trying to set up a better pharmacy programme. And in fact, in that particular case, it was, and we did this, could you lend us some retail pharmacists who will help manage our drug chain? You know, the sort of practical stuff that people want. It's not the only thing, and the danger is that you end up in a clinical model if you're not careful, and you replicate the same sort of stuff. But I thought your challenge to ODI was a great one. You know, because if you go out into the NHS and you meet doctors and nurses, you'll find many people want to get involved in things and would be able to offer something. And with electronic communications, it becomes much easier as well, doesn't it? You know, there are different ways of doing things. So I'll be interested to know where your challenge goes, Enrique. If you're on staff here, presumably you're going to keep saying it. Yeah.
Okay. Thank you very much. I think on that it'd be an interesting area to explore how we can get more communication with some of the specialist agencies and draw them into these debates more. But I think the other thing that was interesting about much of the presentation was the emphasis on the broader social policy issues as well, and the embeddedness within that on the earlier comment. So I think that there are also obviously a set of issues. I'd be interested at some point also to hear your take on the literature on equality and well-being and sort of the spirit level and stuff like that, and how you feel that plays into some of the stories or the narratives that you've developed. But let's move to another round of comments at this point. We had one from here.
Thank you. Thank you, Lord. Do I have to do anything? No. Thank you, Lord Crisp. I couldn't fault...
Can you introduce yourself,
Sorry,
please?
Lou Lillywhite from the Chatham House Centre for Global Health Security.
Not where you used to be from, where we first met.
I used to be armed forces. Thank you. I could not fault any of the theses that you put forward. The issue, I think, is implementation. And I'd like to move to some of the barriers to implementation, if I might. I was very much heartened by your statement about how health can contribute to the other development goals. And I say that because when I interact with DFID and USAID and others, I found that they really thought that health was an outcome as opposed to an input, and did not realise that health could actually enhance education, could contribute to economic development, could contribute to the emancipation agenda. And it seems to me that the medical community on the one hand and the development community on the other hand have failed to actually consider holistically the interrelationship between health and the other development agendas. And the question there is how can we redress that? That's the first point. The second point, you talked, and in the last round we talked about how power disparities influenced it. But interestingly, when you get democracy, that too can get in the way of appropriate development. It's quite interesting when you look at a recent paper on the appreciation by the population of Afghanistan on some of the health development, how low they marked or scored preventive health. They were not inspired by the investment in preventive health. They were inspired instead by high quality treatment. And you see the same amongst governments who actually are more interested in providing the high quality, high tech hospital. How do we actually persuade policymakers in the developing world to see what ought to be good for them, and what do we do when they disagree with us? And then the final point, if I may, is you made much about what we could, in the educational side, offer to the developing world. The problem that I see is that not all, but a large proportion of health professionals who go out in an educational role to the developing world, and indeed some but not all, of the syllabi of the Royal Colleges, is Western orientated. And I found a slight inconsistency between the statement, which I entirely agree with, that we actually need health which is appropriate to the developing world or the country which it is provided, that actually is so for the developed world as well. And the other statement that you made, which is we need our health people, or let's encourage our health people to go out and actually provide it. And I see a contradiction there unless we do something for our health people. Thank you.
Thank you very much.
Thank you. I'm probably going to add to that point. My name is John Pearson. I'm a practicing UK physician and worked abroad and taught abroad as well. And one of my concerns, and this is sort of through... This is through some personal experience. Is when I've been teaching abroad, I think I try and get my head into the health worker abroad and a lot of the push and pull factors that exist for them, the very sort of real factors. And of course, what every professional person wants is a way of improving their professional development and support and ongoing supervision, and it's definitely one of the things that people need. Unfortunately, there are a lot of other perhaps cross-cutting issues that isn't always down to the Department of Health in that country to deal with as well. Some of them are, and certainly working in a safe environment within the hospital is a massive issue. getting reliable pay is a matter. Living in a place, particularly in a rural area, where you can get good education for your children, and you can get to places easily, you can get internet access. A lot of these things are a part of a big package for a health worker to be a happy, valued health worker. And I think in these situations, when I've worked abroad, I've done my best to be doing the teaching side of things, but have been completely swamped with the rest. And it's a very difficult thing to deal with, because I think what you're showing a lot of your colleagues, your professional colleagues you're working with, is that yes, you can provide this information, this teaching, this supervision, and learn from it as well. But ultimately, they're not. They are going to probably want to move away as they're, if they have an opportunity. And it's if the NHS is planning on putting out doctors, nurses, midwives, health professions, administrators, or whatever, to give expertise, is that going to be part of a bigger package to make for more valued, happy workers who are going to stay where they are because they want to stay where they are?
Yeah, very good.
Thank you very much.
Thank you. Hi, my name is Jane and I work for THET, and I just wanted to comment on some of the practicalities around implication of the idea that you could have health workers talking to each other but within the development framework, which I think is something that's a really positive and challenging idea, particularly for those of us like myself who's a development worker. But what we've observed from working at THET is if you can actually frame relationships over the longer term, so you can build institutional links, so you have the same people talking to each other, and then you have some input from an organisation or you have something around this development framework, then what happens is people build in confidence over time. So at the beginning, you are going to have conversations maybe about development principles or cultural interactions, but as people become more and more engaged in their link, that develops and the relationship grows. And by the end of that, I think that what we start to see is the folks in the UK side then do have the confidence to do a lot more listening and learning from their southern counterparts. So it's almost like a cycle. So you come from the traditional idea of somebody going overseas from the UK to deliver some training because they're the expert and somebody else needs to be taught in a certain technical field, and that then really develops. We've seen relationships really build and change over the course of 5, 10, 15 years as people continue to go, and what actually has been learnt on both sides as a result of those can be really very, very positive to everybody engaged in the interaction. And I think the big challenge really is how to take this kind of idea to big aid, because what we see is this works really well at an institutional level where you can keep that going and get those relationships and remove blockages to your local health systems, give trainings, develop ideas. But then actually, how are you then going to change this into a model that could be developed at the highest, most centralised level? That's, for me, is a really interesting question. But I would be delighted to hear about other folks that are engaged into kind of facilitating and supporting professional-to-professional discussions, because it's something that we're still learning about how to do. So, thank you.
I don't know how well you organised this, Andy, but you seem to get three sets of inputs there that fitted together extraordinarily well. Let me start with Louis' three challenging points, which was the business of implementation. How do you shift this? And you know better than I do, I suspect, the vested interests that are in the system that will get in the way of really quite a significant change in mindset. I mean, professionals will sit within their professional structures, even if it's doctors and nurses, let alone doctors and development workers or anybody else. And it's not just, it's not just your profession. That's a real difficulty, which is why I believe that probably the single most effective thing to do is to see the change inside the head of the health worker. You know, that's where I think experience is so important. That's where I think it's actually being out and working with people, understanding the reality, and coming back with the picture that actually I as a doctor can do X, but actually I could do X times 5 if the following other things were in the place and so on. So part of what we've been doing is there is a commission on reforming professional education, which is going to report in the Lancet in December, which is actually chaired by Julio Frank and by Lincoln Chen, and it's looking at doctors, nurses, midwives, and health and public health people, looking across the lot and looking about in this new world, interdependent world, what do we need to do? How do we need to shift it? So I think there's a formal bit which is about trying to shift the next generation in terms of that training. But I think there's also a bit of it about experience and starting to do it so that actually, you know, whilst the mainstream is going here, the pioneers on the side, there come a point where they're big enough to be noticed. And that's how I suspect things will start to shift if we can build some energy around it, and also if influential groups like ODI start saying some of this stuff, and start saying it while standing alongside doctors, leading doctors like yourself. Your point about the really interesting point about you know that in poorer countries, as in the UK, people will have immediate impressions about emergency services and high-quality clinical services, not about preventing diabetes. It'll be treating the complications of diabetes, because that's where we all are. Now, exactly the same in the UK. And I used to have this argument with people in 1999, 2000, as I became chief executive of the NHS, about why are you concentrating on waiting lists? Why are you concentrating on clean hospitals? These sort of things. They're what the public are saying, whereas actually, you know, the long-term burn is actually avoiding people getting diabetes. But you know, in reality, there are some things that are so pressing and so in your face, unless you deal with those and get them off the agenda, you can't get onto the longer term. And I suspect the argument that I would have with Aaron Motsoaledi, because I mean, I literally been having effectively this discussion in South Africa, which is why I'm quoting it, is he and I talking about the fact that you've got to deal with those things before you can deal with the other things. But actually, you need to start the initial steps for the long-term impact at the same time as you're trying to deal with the short term. And we didn't always get that right in the UK, I must say. Though I'd also just make the point, this reminds me of the last question, which is about getting people who've been there talking with each other. I've been interested in all this debate about health systems over the last 3 or 4 years in the development world, and kept asking who's run a health system, who's involved in this debate, you know, where's the practical experience? And that's the sort of practical experience I think one needs to understand, that, you know, the theory is great, but actually political reality, and you've worked for politicians, is you've got to get this out of the way, and it's where the public are. I thought your other interesting point, which then takes me onto Ron's discussion, which is how do you teach abroad? And I think there are 2 themes here. Jane didn't say, but she and I have been working together with Susanna about providing British health workers as volunteers to work within the Zambian health system for training. So a sort of model of what we're talking about here. And that's really interesting. Now, you may know Ken Fleming. Ken Fleming was the head of the Oxford Medical School. And one of the areas they wanted us to work with was pathology. And to create an M.Med, in other words, postgraduate work in pathology. And Ken, of course, coming from Oxford, wants to know what sort of pathology we're talking about, you know, because for the layperson, there's any number of bits of pathology. And actually it started off that it was really anatomy was the very first bit that they really wanted. And so actually what's happened there is that, or what is happening there, I think it's fair to say, Jane, is that Ken is working with local people to make sure that they're actually creating a syllabus that has got some insight from the West and from Oxford, but has also got the local insight. There's a sort of respectful relationship there, and it'll be interesting to see what comes out of it. So that it should hit the scientific rigour, if you like, but it should also be relevant. But also very clear, and Ken's got a model in his own head about actually, maybe that's the first step, but what are the next steps that come after that? But that's the sort of debate. But it goes absolutely alongside the point that Ron's making, is that you can't get on with the job if everything else is getting in the way, which sometimes is true in the NHS too, I believe. But one of the things that Jane's group is doing there as well, and part of the package we put together, because the Zambians asked us to, was to build some houses. So as well as providing British health workers to train some nurse trainers in more rural areas in Zambia, you're also building houses for them. Now, that's not schools, it's not everything else that goes with it, but it is recognising that there is a package that's needed there. And I think, by and large, DFID move in that way, that, you know, there's not a single bullet here. It is the various bits together. Although sometimes you do need to, I do feel that and this goes straight to Jane's point, which is how do you get this right at the top level, is that sometimes what you discover on the ground from your reality of experiencing it doesn't feed back into policy, and you still end up with policy that is developed in a different vacuum from where we are. I mean, Jane's question about how do we move on from trying to understand this at a local level to influence it at a global level, I think it has to be the sort of levers that I've already touched on, including, frankly, ODI. You know, if ODI took this up as a theme and other influential people within this field, they will start to influence the politicians and so on. But I think it'll be a long-term business in terms of this. The other thing, again, as you and I both know, is we also need to be able to demonstrate results, and that actually this had an impact and it wasn't just a nice idea. You know, those are the areas. So these are all unresolved issues, but they feel to me like they're really important ones, and that it's, you know, your experience and Ron's experience and others' experience being able to feed in so that our policy is wise to those issues and can try and make a difference is really where we need to be. Yeah.
Thank you very much indeed. Very pleased to hear the references to ODI's influence, although I suspect that if we're relying on ODI to change the global architecture and health, it might be an extremely long-term job. But anyway, Liam, you have somebody, I think, commenting from...
Yeah, we've actually got two questions, thanks Andy. And the first one's from Martin McCluskey, who works for VSO. Martin says, VSO has been engaged in training of health workers in sub-Saharan Africa for years, so we agree completely that training is key to advancing health systems. We also recognise that migration of health workers is an issue and launched a new report on the issue called Brain Gain a few weeks ago. While, as you say, the numbers may be small, it is often the best and brightest who leave, often removing the most talented cadre of health workers from developing countries. Do you think the government should look again at the immigration system to make sure that nothing is working against development aims, or even look to expand the medical training initiative where there is a clear route of return? And there's another question from Maria in New York, who says, to what extent could performance-based incentives or funds be considered as a feasible effort to link healthcare systems and development?
Thank you very much. Well, I think move to those two. I want to also, again, abuse Chair's privilege and just ask, because a lot of the discussion has been at the national or local level. What do you think would need to happen in the global architecture for learning? I mean, you're talking about a new paradigm that's based on a global approach to health, interdependence, these kinds of ideas. One would think you'd need transnational institutions, whether in civil society, the research community, or obviously public institutions, to facilitate that. So where do you think we're at on that? Do you think we have the institutions and it's just a change of paradigm, or do you think we would be short in that area?
Just conscious of the time, there were a couple of other questions. Should we take those now
sorry,
as well?
Should
we take those and then I'll
try
and
we'll
do
take those and then
one wind up, as it were,
Oh, Jane Cole, independent consultant. Regarding the unfair health trade, the VSO...
Did you say ophthalmic consultant?
No, independent.
Independent.
Sorry.
I thought you were ophthalmologist.
No.
Come back with cataracts.
Yes, on this question of unfair health trade, really, I suppose, backing the VSO question, I mean, one has this problem of this huge differential in salaries of health workers around the world, and I can recall being in Guyana not so long ago, and I was being told that half the newly qualified doctors were leaving for higher salaries in nearby islands, paying like Barbados or America or even Europe. And, you know, as long as this situation arises, what they were doing there was training more nurses. I think the hope was this was at lower cost and would help in the rural areas, certainly, and also that the nurses were more likely to stay and less likely to migrate. My second point was regarding the movement of health workers to developed countries, such as the UK. There have been proposals put forward that the government should perhaps compensate the poorer country for the training that they've provided to the health workers before they come. I'd like your view on that.
Thank you.
One of those or not?
No, I think we're...
Okay, great. Well, again, these sort of fit together, don't they? Let me pick up on that last one, which links back to VSO and the migration issue. Migration is a significant issue. I absolutely take the point. We looked at the figure. I actually did a piece of work in 2008 with Bint Gouanas, who's the Commissioner for Social Affairs for the African Union. She and I led a working group looking at how you'd get a scale-up of health workers in Africa. We looked at the figures, and there were some really interesting figures about migration. One of them was that in Uganda, nurses going into training, 30% dropped out before they even got to training, and then another 30% dropped out before they went into they worked in the Ugandan health system. So 60% disappeared. Now you look at what happened within that, and I think some of the first things you need to be addressing, and people are trying to address this, is the recruitment, actually. You know, why were people coming in the first place? Were they choosing the right people? What was the training program like? Where were the holes in the system? So it's quite a complex sort of picture around migration. One of the things that came out of that we then moved on to later on was that the World Health Organization, as people probably know, this year signed a code of conduct on migration. I don't know if people saw it, but it had two parts. And the first part is sometimes forgotten, which is the rights of migrants. You know? And none of us believe that countries should keep you in their borders, do we? I mean, you know, people have rights to migrate. Ron made the point about doctors not being paid. You know, if you're in a country where the doctor hasn't been paid for 5 months, well, why wouldn't they migrate? You know, it's remarkable that they don't. You know, there are some real issues about rights of migrants to migrate, and then their rights when they get it wherever it is they've gone to. Because again, migrant workers can be quite seriously abused. So that was part of the code. The other side of the code was saying that but countries have a right to have an expectation that, you know, health workers they train, that they get at least that value back in terms of health workers in their country. We looked at compensation, but if you did the compensation of, you know, 100 quid per head as they shifted around the world, you know, a sort of football transfer fee, as some people have suggested, you look at that and you quickly realise that that's nonsense, because A, many migrants move more than once. You look at and will not only come to this country, get training and then go back. So who's paying whom in that relationship? Because there's been the training gained. A lot of them go to America as a last resort. A lot of African migrants go to South Africa. You've got a whole lot of difficult ways of trying to sort of identify who would be paying whom, how you get the mechanism right. I mean, bureaucrats would love this. You know, this would be, I mean, the WHO quite liked it as a starting point. So it sounds like a lot of interesting work, doesn't it? But it's a waste of time, in my view. My view, and the one that I've taken all along, and the one I'm happy to say the Code of Conduct took, was that actually countries that have gained, like the UK, have a responsibility to support the training and education of health workers in the country that people came from, and that the compensation should be in that form of providing training and education in those countries. And remember, some countries, even some poor countries, want people to emigrate. You know, not because they don't want them in the country, but actually because it's a good source of income for them, and you know, various people have wanted to do that. But I do think there's, I'm afraid I haven't seen. I knew VSO, Martin. I knew VSO were writing that report. I haven't seen it, so I better make sure I get it. But there are things that people can do around migration against that wider context, but a lot of them are the responsibility of the government themselves in that particular country. And I hear African doctors saying to me, I do wish Africans wouldn't talk so much about migration. It lets their government off the hook. You know? There is an issue here for some people that actually, if you focus only on migration and blaming the West and rich countries, you'll miss out on where a lot of the solutions got to come from, which is actually countries themselves treating their health professionals in an appropriate way. And I think part of our role from the West, again, is advocacy about that. And again, I don't know whether the VSO document picks that up. But I do think we can increase the MTL programme, which was referred to. Maria, I think, asked me about performance-based funds to link healthcare and development. I'm not sure exactly what you mean technically around that. I'm always slightly worried about, I mean, certainly whatever you're doing should show results. I'm quite worried about performance-based results from experience in some other areas because people are so bad at measuring what they mean by performance. And that is true when we've tried to do that in the NHS as well. So I'd really like to see something well designed, and that you do know that when you end up in performance-based reward systems of any sort, you end up with some unintended consequences. So how are you going to manage the unintended consequences? So that would worry me. I remember when we were running the NHS that at one point our waiting list target was 6 months, and people thought that was good enough. 6 months isn't good enough. Actually, what you're trying to do in the NHS was get rid of unnecessary waiting. You know? And so the target became the thing that you were sort of aiming at, whereas actually you were really looking at patients, you know, being able to live their life and without being kept unnecessarily hanging around. So I'm a bit worried about performance-based funds in that sort of context. Having said that, you can't rely on things that are just about inputs. You need some outputs. You've got to be able to measure the impact of this stuff. And this government, this new government, who I think should be applauded for definitively aiming for 0.7% as the British contribution to international development, are right as well, it seems to me, in saying they want to know what they're getting for their money. You know? But how you do that, don't let's pretend we know the science of that yet. Again, I think that's a very big and very big significant area. And then the final thing was your point on global architecture, actually, Andy. And I'm not sure. I think what we have to do is to use the global architecture that's there. And I think the Code of Conduct on Migration was quite a useful one because it contains a number of assertions within it that are more in line with the paradigm that's coming than the paradigm that has been there. It's more about people than it is about professions in a way, and so on. So I think there's a bit about using current architecture, but I also think there's a bit which is about how I try and describe in the book is about creating a movement around this, you know, and that actually people, like-minded people working together reinforce each other. That the more that we all understand some of the really interesting stuff that BRAC has done and what it means for health, the more in terms of was it Enrique who was sorry, it was forgive me, it was Mike who was making the point about siloism. You know, the more actually we understand things across boundaries within this, and the more that we keep pushing that. So I'm not a great one for thinking about particularly the architecture, because I think, you know, if you can move Richard Horton at the Lancet, who's had a great thing on global health, to a bit more in this direction, if you can, you know, use this Education Commission report that's coming out again in the Lancet, if you can use organisations like yourselves and others to start to shift it, I would be worried about trying to make big institutional change, which I know takes 3 or 4 years, by which time you've all moved on. But actually trying to get the best out of where we are. And see it much more as a bottom-up movement, which at some point needs to connect with something top-down. But that's where you may find that amazing as somebody who ran the 4th biggest organisation in the world, but actually I think the bottom-up change will be more effective, certainly in this case. Thank you.
Look, Chris, thank you very much indeed. A very interesting and challenging session in an area that, as you say, we haven't had too much specifically on health at ODI before. Thanks also for the challenges to ODI, and I will, I think, get together with Enrique and we'll respond to you on some of those, particularly on the technical networks and how we can look at those. So we look forward to being in a dialogue with you on this going forward. And thanks very much also to the audience and for all the great contributions. Thanks a lot.